there were 43 cases. All cases were reported. In the 60s, the quoted prevalence is 1 in 30,000. In the 70s, with the introduction of the CTG and the associated increase in cesarean section rate in the hope of decreasing cerebral palsy, but it didn't happen. The rate increased to 4,000. In the 2000, it was 1 in 500, and the most recent global rate of placenta accreta is 1 in 200. So, and this is like mirrored by the increase in cesarean section rate. In 1800s, almost no cases of cesarean section. It was only reported cases that cesarean section is done. And then in the 1900s to 20s, with the industrialization and so on, there was rickets which affected the pelvises of women. So they introduced cesarean section. Later on, with the milk and improvement in feeding, the pelvises or the rickets subsided, but the cesarean section rate did not decrease. So, and again, in those days, most women deliver at home, so it is not hospitalized patient. In 1940s, 50% of women delivered still at home. By the end of 50s or mid-50s, 99% of women delivered in hospital. And this is another reason why normal birth is decreased, because we are treating vaginal delivery as if it is a disease and it has to happen in the hospital. So the rate now of cesarean section is somewhere between 5% to 50%. The 5% in areas where there is no access to hospital. So in sub-Saharan area, it is in that range. And the accreta in that area is also very low. If you look at the rate of accreta, for example, in sub-Saharan, I could not find, except for a few cases, 6 cases reported, because they have very low cesarean section rate. So to start with, thank you to the committee of the scientific committee of the symposium, because this is really one big aspect. Then this leads me to how do we decrease, is it just by reducing the cesarean section rate we will end up with reduction in accreta? Yes, to a certain extent, but there are other causes. For example, IVF, previous myomectomy, previous surgery. And maybe we will not be able to reduce cesarean section rate to the rate which is acceptable, but the improvement in surgical technique, early diagnosis of scar ectopic, and early second trimester diagnosis might help in the prevention of morbidity and mortality of placenta accreta. So if we say to reduce accreta, we need to reduce cesarean section rate. What is an acceptable cesarean section rate? The World Health Organization suggests that a rate between 10 to 15% is acceptable rate, because if you have no cesarean section at all, it means that a patient who has breech, the baby will die. A patient who have difficult labor or dystocia, she will be having prolonged labor and she might even die or develop fistula and so on. So the sweet point is around 10 to 15% without increasing the maternal mortality, and at the same time without risking the baby. طبعا this rate will be variable according to the population. If you look at hospital data, I'm sure the rate will be much higher. And I will show you just in Saudi Arabia, the rate of cesarean section. طبعا the data is available for Ministry of Health hospital and other governmental hospital. The number of deliveries is just a little bit less than 500,000. 200,030 are in hospital of Ministry of Health, and the prevalence of cesarean section is 36.5. In other hospitals, very similar. In private sectors, there are 179, almost 180,000 deliveries, but there is no report for the cesarean section rate, which is, I don't know, is it the data collection or the private hospitals are not giving the exact rate of cesarean section? Because all other hospitals, whether it is Ministry of Health or university hospitals or military hospital, they give the data, and it is available if you want to look it up. The highest rate was in King Faisal Specialist Hospital, but this is understandable because it is a referral hospital. And if it is not a high-risk patient, again, most of those who are low-risk delivering in King Faisal are VIPs, and I will come to that point, which is related to the choice of women. And some women will request, and most doctors will comply with the patient request. The good news is that in the Eastern Province, we actually have the lowest rate. The lowest rate for cesarean section is in the Eastern Province. It's around 22.4. In General Hospital, the highest rate is in Hail and Qasim. So these are the statistics in Saudi Arabia. So in areas, the 20 or around 20, acceptable, but still we need to lower it down. But in areas where it is in the 40s, it's almost one, it's approaching like one will have cesarean, one will have normal vaginal delivery. In our hospital, we chose to follow the very low-risk patient, which are bimigravid, they don't have any disease, cephalic presentation, no medical disease, normally grown baby. And we follow because we want to decrease the cesarean section rate, the primary cesarean section rate. And we find that there is variation. We started collecting data in 2014, and we were almost up to 30%. So 1 in 3 women end up with cesarean section. And surprisingly, if you look at something and you alert your group that we will follow this practice, for example, you see that there is a drop in the cesarean section rate among bimigravid women. In some years, it reached to 10%. And then sometimes you have increase. Is it all a good thing to reduce cesarean section rate? The benefits of cesarean section rate. In addition to maternal complication, you are also increasing the chances for women with previous cesarean section to have vaginal delivery. You will have shorter recovery if the woman deliver vaginally. The cost, the actual financial cost of vaginal delivery compared to cesarean is much lower. Increased, bonding of the mother, reduce the risk of placental abnormalities, and other intervention which are not, which can be avoided. Is there risk for reducing cesarean section rate? If we aim and we are very adamant that we need to decrease cesarean section rate and we take all the measures to decrease it. Is there any risk associated with decreasing the cesarean section rate? Yes, there is. If people are very adamant to deliver vaginally, sometimes there is associated risk of birth injuries. You know that this case, for example, might be not fit for vaginal delivery, but in your heart, let me try vacuum, let me try forceps. You might end up with. So it's always the decision of the senior consultant. Risk of uterine rupture and VBAC, impact on maternal mental health. Some women, if they will come to you, I want cesarean, and if you say no, she might go to another hospital, and then if they refuse, she will go back to you. And if she doesn't want to deliver vaginally, and you force her to have vaginal delivery, this will be a very traumatic experience for her if she doesn't want vaginal delivery. How to decrease cesarean? By decreasing elective and emergency. So we will go through some of the indications for both elective and emergency cesarean section and see if that can be decreased. So elective cesarean section, by elective I mean maternal request. So she doesn't have anything, and she just say, for example, that I don't want to come in the middle of the night. I want everything to be organized. I want to come in the morning, have my baby, and go home the second day or the third day. This is a very a huge topic, and there are some intervention program where they have obstetrician educating the woman in during the pregnancy, as well as midwife educating the woman, and trying to resolve this problem, because you as a physician or a midwife, you want her to have vaginal delivery since she doesn't have a problem, but it takes a lot. So this is a huge subject, but one aspect of doing it is أتذكر some years ago there was like a campaign القيصرية اضطرار وليس اختيار كان عنوان الكامبين هذا. So it needs some kind of education for the patient. The other ways is by decreasing the cesarean section rate is by offering vaginal birth after cesarean section. And for this, to encourage, first of all, the choice of patient, which patient to allow for vaginal delivery, and by in most hospitals, they allow vaginal delivery after one cesarean. In some hospitals, even after 2 cesarean section, in selected patient, you allow vaginal delivery. And this goes with the recommendation of the American College. So the recommendation of the American College, based on consistent scientific evidence that most women with one previous cesarean section, low transverse cesarean section, can be counseled regarding VBAC. Epidural is okay, because sometimes you hear some concerns that we will not give epidural because it might mask the scar tenderness, which is not true. If you are going for VBAC, you should offer the patient if she wants epidural. The evidence for the 2 cesarean section, again from the American College, women with 2 previous low transverse section delivery and no contraindication who wish to attempt VBAC may be allowed a trial of labor. And in King Fahd Hospital, we have delivered many patients with previous 2 cesarean. So the management or how do you deal with patient with previous 2 scar is exactly like one scar. You are looking for signs and symptoms of scar dehiscence. The only difference, of course, is that we don't use prostaglandin. We use oxytocin if needed, but not prostaglandins. And if we need induction, we usually go for the balloon catheter. What makes a normal vaginal delivery a happy experience for women is usually the people around her. So establishing a good support program, because the main difference between vaginal delivery and cesarean section from the perspective of women is that vaginal delivery is prolonged process, while cesarean section, 30 minutes and she will be out with the baby. So those hours, if it is a bad experience, or she hears previous bad experience of patient, and patient usually they tell each other, this hospital, that nurse, that doctor, so word of mouth is very strong. So those who are encountering women during delivery, they have to have a very good support for the mother during labor. And this support includes emotional and physical support. Okay. Other ways of decreasing cesarean section is by offering external cephalic version for all eligible breech patients, because by that way you will allow more women to deliver. And again, twin pregnancies, if the first twin is cephalic and the other twin is normally grown, they should be allowed for vaginal delivery. All these things are just related to general. But if we want to say from our perspective how to decrease it, it goes back to 3 things: fetal distress, failure to progress, and failed induction. And in these three, يعني طبعا في السكند, this is in the latent phase. In the second stage, also failed instrumental. So if we look at these four things and we look at it really critically, I think we can يعني decrease the cesarean section rate. CTG is number one in our hospital. For example, in the primary gravity patient, يعني almost more than 60% of patients taken for cesarean section are because of what we think is the baby is distress. And actually the baby, most of the time, not most of the time, almost 99.9%, the indication is fetal distress, and the baby's Apgar score is 9 and 9, and BH is normal. So it means that the baby is not in distress. The doctor is really in distress. He is the one who is يعني, not feeling happy about the CTG. And one way of improving or decreasing the cesarean section due to fetal distress is by improving the knowledge regarding how to read CTG. And I'm very happy that in the Eastern Province, almost every year there is like 2 or 3 courses. So the upcoming course in Qatif, 5th of March, and we have another course upcoming in April in King Fahd. Why I'm saying this? I'm not saying that the senior person doesn't know how to read CTG, but if you are in the middle of the night and the first responder to CTG is usually R1 or the nurse. So if she says fetal distress, automatically the person who is responding to that call will come already biased that there is something wrong with this baby. And if the consultant is at home and the registrar calls him and say CTG is so and so on, most of the time the answer is, okay, take her for cesarean section. And even you yourself, when you are reading CTG in the middle of the night, and then you look at it critically the following day, you will most likely change your mind. So it's really something to look at. In some hospitals, they stopped responding to deceleration, and they only look at baseline variability. And if the variability is intact, it means that the BH of the baby is intact. So this is something to really look into because it is contributing to a great degree to the cesarean section rate. طيب. Other ways that can be be done to decrease cesarean section rate. الحين مثلا in any decision, usually 2 brains is better than 1 brain. So one way of doing things, I know it's sometimes difficult, but it can be tried, is that when there is a decision for cesarean section, it should be 2 consultants for the emergency cases. Just a trial, do it and see how it goes. And review your data. If you review your data, because it is under the microscope, you will start seeing things differently. And by reviewing the data, select one group, because it's very difficult to look at all patients and say we are doing fine or we are not doing fine, because each hospital has its own population. So select one group. Don't look at the data as one group. In the private sector, one way of decreasing cesarean section rate, which has been recommended, is to give incentive for normal birth. Because we know normal birth takes more time, more effort, more time for the doctor. So it's unfair that a cesarean section is valued higher than a vaginal delivery. So by giving incentive, I'm not saying that the doctor is doing the cesarean because he wants the money, but if you give incentive, it makes it more worthwhile for some people. So this is regarding fetal distress. Education. It has to be to start with education. Failure to progress is a more problematic area, because first of all the history of looking at labor is really problematic. So when we talk about cesarean section in the latent phase, when does the latent phase start? Does it start with the patient presenting to the hospital with the first examination, ولا من أول مرة بدأ عندها الألم وهي في البيت? And when does it end? 3 or 4 or 5 or 6 centimeters. So if you cannot even يعني with accuracy define when does it start and when does it end, then you are really in some trouble. The active phase is the end of the latent phase, which we are not yet sure, but it ends with full cervical dilatation. So one thing that has been done to decrease the cesarean section rate in the latent stage is by, وهذه توها يعني يمكن only since a few years, by changing the beginning of the active stage. So you cannot say for somebody who is contracting, for example, and still 3-4 centimeter, and you examine her now and you examine her 4 hours later and say she has failed to progress because she is not in active phase. So they changed the threshold for active stage to 6 centimeter. And this is not based just to decrease cesarean section, because labor is variable. And how many times we see patients spending 12, 18 hours to reach 6, 7. And then after that, she shoots very quickly. So the slope for the labor is very variable. So one thing is by saying that active phase start only at 6 centimeter. So by this way, you cannot have failure to progress in the latent phase by applying the same criteria. But there is also protracted labor. In the latent phase, how long can you leave a primagravid patient contracting adequately without saying that we have failed to deliver her? The time is up to 18 hours. So this is very different than when you label her as active phase. So one point is the 6 centimeter, and I think it's very good change to avoid failure to labeling women as failure to progress in the latent phase. طبعا by labeling women as failure to progress, it means that we are examining them. And if we examine frequently, then we will end up labeling them as failure to progress more frequently. In a Cochrane review, they looked at routine vaginal examination versus ultrasound, or routine vaginal examination versus rectal examination, or routine 4-hourly vaginal examination versus routine 2-hourly, or routine vaginal examination versus examination as needed, as indicated, if there is changes in the CTG or the woman feels the urge to push. And in those studies, there is nothing better than the other, but they tend to better to not examine the patient every 2 hours. First of all, it's not acceptable for the patient. And second, it might increase your tendency to interfere earlier. So their conclusion is based on the finding in these studies. We cannot be certain which method is most effective or acceptable for assessing labor progress. And far more trials needed. But these should include essential clinical and experimental outcomes. And data from these studies are also need to assess and evaluate the labor progress. So actually there is no conclusion which method is the best, but they recommend a little bit that you don't need to intervene every now and then. طبعا والنقطة الأخرى the other point regarding cervical assessment is that in hospital it's not usually the same person examining the patient all examination. So the agreed cervical examination between different doctors or midwives and doctors is 50%. I could come and examine and say she is 6 centimeter and label her as active phase, and somebody 4 hours later examine her and find that she is 4 or 5 centimeter, and because I am senior, he will be shy to say, no, your examination is not right, she is not 6 centimeter, and he might agree with me that she is active stage, while she is really 4 or 5. So the observer variation is very high, and the accuracy is higher at low examination. طبعا once we say fully dilated ولا 9 cm, the variation is very little. But in early cervical assessment, the variation is very large. طيب. there's طبعا the يعني new research regarding the use of ultrasound or using other methods to assess the cervix, but يعني this is more like in research area. But one small technique that I find very helpful in the decision whether to go for يعني especially in the second stage to go for cesarean section or try instrumental delivery is just by putting the ultrasound on the abdominal wall or in the vulva and ascertaining the position of the baby. يعني if you see the orbits up, then even if you are going to apply your vacuum, and I'm saying this from experience, يعني sometimes during labor, especially with pushing, you cannot يعني with 100% accuracy even ascertain the position of the baby without يعني with great accuracy. So يعني if you have ultrasound, this will make it easier to decide. So there is يعني a lot of talk about the use of ultrasonography in assessing cervical dilatation and the progress in labor. So from what I'm يعني saying for the last few minutes, failure to progress is the part which is surrounding with more questions than answers. لأن فعليا the way that we are doing it is يعني faulted with so many things. So vaginal examination, although it is يعني if we say for example mammogram is the screening test for breast cancer, our screening test for dystocia is vaginal examination, which is not accurate, which is not acceptable for the patient, does not cost anything, but it has negative predictive value and positive. وطبعا for fetal distress our screening tool is CTG صح؟ و CTG الفولس positive rate is كم؟ 50% false positive. يعني when I say CTG is showing changes, what is the likelihood that the baby is really having asphyxia? Very low. يعني الفولس بوزيتيف إن فعلا يطلع البيبي عنده مشكلة is very high. يعني imagine if we do mammogram and do mastectomy based on a test which is 50% false. This is what we are doing with CTG. So both CTG and cervical examination are not really accurate. So going back to the latent phase, avoid admission during latent phase because if the mother is there, she will tend to have more intervention. Follow the ACOG recommendation of 6 centimeter mark for the active phase. If in doubt, and the doubt is always there, especially with 2 examination, give the patient time and examine her a little bit more. And refrain from having the epidural very early in the latent phase. One thing that might be helpful is that in the Saudi Vision 2030 is to have a midwifery-led maternity care. طبعا this is based on a lot of data showing that the vaginal delivery in midwifery-led unit is much lower than hospital or physician-led hospitals. So spontaneous birth per 1,000 for midwife is 765. For obstetric unit 688. طبعا حتى الأشياء الأخرى الابيزيوتومي مثلا blood transfusion, all these are lower with when midwives are taking care of the babies. طبعا في home delivery, but I think we are not yet there because we don't have outreach services for the. But if you look at the spontaneous vaginal delivery, it is highest with the freestanding midwives. Okay. We as physicians, I think we usually state that we don't have any conflict when we are dealing with our patient. But when it comes to cesarean section, I think we have great conflict of interest. When we deal with patients, even if you are the most honest person in earth, كذا at the back of your mind you are thinking about yourself. What if I did vacuum and the baby end up with asphyxia? Which is true. I feel it. When I do vacuum, any vacuum I do, or any when I wait for the CTG for longer hours, at the back of the mind, I don't feel comfortable till the baby cries. So, because you want the best for the patient, but at the same time, you are thinking of yourself. طبعا not just yourself, the safety of the baby itself. In training center, also I find this very prevalent, that because the young doctors, they want to do cesareans. For them, vaginal delivery is boring. It's nothing to do vaginal delivery, although it is an art in itself. I think vaginal delivery is an art that we are losing a lot of things during the vaginal delivery. But for the training centers, sometimes the decision for cesarean section might be affected by the people wanting more more exposure. طبعا financial conflict, this might apply also in private sector, although I don't think it is the main drive, but time for money. If I spend 12 hours just watching this patient, I'm losing more than if I come 9 o'clock, do the cesarean, half an hour, I gain more money than أسهر طول الليل. So in summary, to decrease the cesarean section rate, the best is midwifery-led units. It has been shown that midwife or freestanding, طبعا when they say freestanding, it means that the midwife is like taking care of the patient during pregnancy, delivery, and after delivery. In those units, the cesarean section rate is the lowest, and our Saudi Vision is going with that, inshallah. Hopefully, it will be in the coming years. Allowing prolonged latent phase, so don't interfere based on time in the latent phase. Considering cervical dilatation at 6 centimeter rather than 4 centimeter. And if you want to make a mistake, make the mistake towards the lower end. Rather, if you are doubting, is this 5 or 6? Say 5. If this is مثلا 4 or 5, say 4. Just to give the patient the benefit of the doubt. Allowing more time for labor to progress in the active phase. Allowing women to push for at least, in the second stage, even the criteria are changing. If she's primary, we allow her to push up to 3 hours or 4 hours if she has epidural. For multi, up to 2 hours. Or up to 3 hours if she has epidural. Using technique to assist with vaginal delivery, which is the preferred method when possible. In the second stage, would you rather go for vacuum or go for cesarean section at fully dilatation? For me, it's a nightmare to take a patient at fully dilated for cesarean section. So always think of doing instrumental delivery. طيب. So the last slide is just to say that the cesarean section is mainly through or for 3 indications: fetal indication, maternal indication, and physician. And I think most of the cesarean sections are because of the physicians. So we need to be patient, very patient with our patient, and give them all the time they need to just go through a vaginal delivery. Thank you so much.
Thank you so much, Dr.
Thank you.
Noura.
Okay.
Any questions for Dr. Noura? Yes.
Thank you very much for a wonderful lecture. Great way to start the day. I also think also that the organizers will be able to give us some of these materials so that there are a lot of good information. Now, about this midwifery-led delivery being lower than obstetricians, midwives are known to have low-risk cases than doctors, than physicians. In this studies, did they equally distribute low-risk cases to the two groups before coming to the conclusion that midwives have lower rates? Because if they have higher rates, because if that is not the case, I wonder if that conclusion could be the same. Because naturally, midwives cases are selected to be low-risk cases, and physicians are known to battle high-risk cases. Just like referral institutions are known to have higher cases, for which we're giving them concession, they will have higher realization rates. Was it taken into consideration?
Yes.
No, yes, okay.
Yeah. These studies are from UK and they compared primary gravid patient. So طبعا you are right in saying that a midwifery unit automatically it will be low risk patient, primary gravid or even bara 1. So, but the comparison is actually with one group because as you know, cesarean rate compare within one. You cannot compare the whole group and say this is lower rate. What we يعني طبعا earlier like maybe 10 years ago we did have midwifery masters in midwifery, and usually those who join it are the graduate of nursing school, but the Ministry of Health vision now is that midwifery it should be like completely different from nursing school. So for us in Imam Abdurrahman, what we have is nursing college. So even that program, the master degree, they stopped it. But the vision is actually to have midwifery schools rather than nursing school, يعني in addition to nursing.
That's the thing. I was just thinking about my experience for 15 years regarding this midwifery diploma. They call it. You know, we have been fighting for it to initiate it in our hospital, and at the end, we managed to give this diploma in collaboration with the FMNC, Integrated Medical Complex, and the Airbase as a mutual program.
Yes.
What is my point? I'm really happy that they stopped the midwifery master. What's the issue about it? We, at the beginning, we tried to say that we needed, it should be a nursing base so that we will build it up. Unfortunately, to prove its failure, and I really now, we are heading toward not to go for it, but since we fight for it for 15 years to get it, because we think quality of delivery comes with midwifery than anything else. What's our problem with this master degree? Most of the graduates who graduated from master degree, they want to be in chairs. They don't want to be in a practical.
Administrative, right.
They want to come and be mudir kabir, and they are not even willing to teach. Even when we graduated them, we were very happy with them, and we told them that you will be the pillar and the pioneer in this program. Nobody wants to help. We were really in a shock. Where are you? They're not even inside the labor and delivery room. From there, now, I'm working now in National Guard in Al-Hassa, and next to us is King Saud University, which is nursing also. So I'm really hoping, to do all of what you said, as long as there is a physician who is hungry for cesarean section and for the knife before the assessment, proper assessment, then we need proper midwifery program. Now, when they come as a high schooler and they go for the bachelor midwifery,
yes, you are absolutely right.
In the unit, and by that we can establish proper unit, even clinics they can run.
Yes.
Okay? We can initiate the proper midwife thing. So I hope we don't go on with this master because it's a total failure, honestly. And now we should really get back. And when we talk about master, let's forget about it and initiate proper midwifery program. which is a bachelor degree.
I couldn't agree more. The same experience with us, because somebody who has bachelor degree, when they take master, they want to to be upper in the ladder, which is true. But we have very good we always compare midwifery in UK, midwifery in UK, because it is one of the best system. But here in Eastern Province, yes, John. Yes, you are right. John Hopkins Hospital, they have midwifery-led unit, clinic, and they have also the service in the labor room is mainly midwives. They run the show. They call the doctor only if there is changes in the CTG or she feels that really she is delayed. And they have one of the lowest cesarean section rate, although their number of deliveries is declining, but their cesarean section rate is really low. Okay. Yes, doctor.
Thank you very much, for this nice speech. I have the same lecture I used to present it in so many places, reducing cesarean section rate. That was 15 years ago. The causes of the increasing rate of cesarean section are known. You see, you can enumerate them. The ways of trying to reduce cesarean section is also known, but the problem is in the practice. So that training, you see, is the most important for all people. So that training the junior for doing instrumental vaginal delivery is very important. Training the junior of learning how to read and how to interpret CTD is of utmost importance. And then the other points you see like create and phase and this should be understood. So that all these steps and all these, as you have mentioned in your slide, are very important. Regarding the midwifery units, you said it is a vision of
Yes.
2030.
Yeah.
I hope we are not waiting for 2030 to start the program.
No, we started. The reality is well established. Now it's heading toward Jeddah. We really need it in Eastern Province. We need to establish it. Yeah, we need to start it in university.
And I mean globally in the kingdom, so that because I know this. You see, we have it here. We have it in UK, and the problem here, which I have seen as Victoria mentioned, you see most of those who are getting master or this, they don't want to work. They want to be senior. They want to be in office and these things. So that the midwifery training, you see, during this study should be focused on that purpose.
Yes.
So that to be in a midwifery-led maternity. And this is for a long time for them in UK. And the midwives there are very motivated, so that you have to motivate the people here. That in the training, you have to be motivated. When they are having their patients, you see, if any patient goes for cesarean section, they feel very sad.
Yes.
But this attitude, what should be implanted in those who are going to carry this task?
Absolutely. Thank you so much. Yes.
Thank you very much, Mr. Dr. It was a very, very nice lecture.
Thank you.
I think we are putting little effort. I'm talking about myself, doing what I'm seeing in another hospital, in patient education, which is, we have to put this effort really. Because whenever the patient became fully dilated and we give her the choice for experimental delivery rather than going for cesarean section, a lot of patients preoccupied by the idea of complication for experimental delivery. That's why I think that we have to put our hand over each other, and maybe we need to put an application, or we need to put a website, or we need to initiate a new thing, a patient portal, to put for them a video. And all the schools, they are gathering the patient in the corridor, giving them lecture, which I think is not applicable anymore in this time time being, but video, educational material not exceeding 10 or 7 minutes will work much bigger than giving a lecture for people in the hospital. And we have to remember that in most of the center, rather than, I don't know if it's applicable for security force or National Guard, where they have their targeted patients. But for teaching hospital, for municipal health, for call and security, we are getting more than 50% of our patients, they are not booked. We don't know anything about them. They don't know anything about us. So this media, it is our time and it is the future. So I think we have to work with educational material which can be sent officially either through the ministry or through the university or through any other place. Maybe we'll have a portal where we can share, distribute, because to prepare such material is not that easy. It takes from you months to get out with the material. Unless you are in a place where you are served by a group of interesting also IT who can prepare this material and distribute it. I think we have to, if we really want to reduce the issue of cesarean section, patients they are completely defined by the idea of cesarean section better than normal delivery. Last week I have one patient, she said, I don't want to be destroyed from down. Very frankly, she is thinking that her mother, she is having incontinence, blah, 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 because she has the vaginal birth. So if we start educating our patients, we can work together with educating our doctor, midwifery, all the points which you said, it is excellent, valid point for us. But we have to put some burden on the patient education. Thank you.
Dr. May, you have done this like campaign for the patients, right? Yes.
Excuse me? Yes.
Yeah, I have 2 points regarding the income of cost. Regarding the midwife programs, I think if we think about their income after they took the degree, if she choose an office work and the other one working in labor home, they have an effort and practice. Yani if they know that they will lose some of their income if they lift the practice to an office. And this sponsor will pay money for them to teach them, to learn them, and by the end, they lift all this to sit in an office. Yani it is really losing money for them to teach them, then they will lift all these teachers.
Yes.
I think if we put some agenda for them, if you stay there and you practice whatever you teach there, you will have your income fully, but if you lift it, you will lose something because you are not practicing anything, you are just doing an office work and paperwork.
I think the vision is in the, I'm not sure, but for doctors, for example, it applies the same. Obstetricians are paid exactly the same like dermatology. So somebody who is spending actual physical hours in the hospital is like somebody who is sitting at home. I am sitting in the hospital when I am on call up to this time. My brother, he's psychiatrist. Since R3, he's taking the call from home. And nothing will bring him to the hospital. Even aggressive patient, they will involve security. So you are very right. But in other places, for example, in UK, hour for hour, if you compare the rate of hours for the midwife, it's actually higher than the trainee. So, although we don't like to talk about money, but money is one of the driving forces for doing, yes. So what you're saying is absolutely right, and I think this is coming. Even for the Ministry of Education, they are thinking of doing like 2 contracts for the doctor, one for like any other faculty. So he will be like somebody who's teaching math or teaching literature, and then he will have pay per service contract. So a doctor who's working is not like a doctor who's just giving lecture and not attending any ORs or calls or clinics.
The other point regarding cesarean cost, cesarean because it's less cost. Vaginal delivery, they need more manpower, nurses to stay with them for long hours, and doctors. I don't know if we change our practice, we will have a problem also in the patient to choose cesarean, which is less cost.
Yes, but the vision.
Same time, we will force the private sector to increase the rate of vaginal delivery. They will not choose cesarean because it's a higher cost. This is not يعني سلاح ذو حدين زي ما بيقولوا.
Yeah, for the Saudi vision is that everybody will have insurance يعني, from the government. So it is not an issue for the patient, but it will be an issue for the institution. If they have more money coming from vaginal delivery, they will opt for vaginal delivery as long as it is safe. We are not saying that we don't want cesarean. Cesarean section is one of the best intervention that happened. Women used to die because of difficult labor. So what you're saying is very true where the patient is actually paying. But in Saudi Arabia, يعني, nobody, يعني, unless يعني, cash patient. But most of the patient and the vision is actually to have everybody insured يعني, from the government.
That's why we increase the price of vaginal delivery more than the cesarean. So this will push the private sector to make the
Vaginal delivery.
higher.
Yes, absolutely. Yes.
سؤال صغير دكتورة نور.
تفضلي.
يعطيك العافية دكتورة.
الله يعافيك.
دكتورة الحين our culture has been changing. يعني I face in private hospital. The elderly bribe me, their requests, everything. Now it's coming on the trend as يعني I'm seeing in private, I'm seeing a lot of elderly bribe me coming 35, 36, okay? And they request cesarean.
Yes.
Okay, they request cesarean, but there is a big topic, big section of topic text, patient requests. Patient requests. This is my dilemma.
Yes.
Patient requests, and she has the rights.
I had my first baby at 36. So I don't like يعني, having the age as an issue. يعني, so it's not really an issue. Yes.
But nowadays you see maybe
Yeah.
elderly couples now coming, you know, our Saudis, different culture now coming on.
Right.
They will have contraception for the last 5 years. They will figure out to get pregnant at 35, 36. This is what I'm facing on a daily basis,
Yes.
the private hospital.
I face it also,
You know,
yes.
very difficult for me. I'm explaining consented state patient requests.
Yes.
She told, you know, if she saw me, I mean, they will tell patient requests. This is one issue. The second issue, Doctor, I believe on training. I believe training our residents. I believe the consultant to be with the residents. I believe we have 24 hours on call in King Saud Medical City in hospital consultant home.
Yes.
And how we have been trained. We have been trained when we are the consultant with us, the consultant with breech delivery, the consultant with us instrumental delivery all time. But nowadays, these young consultants, you know, question marks. Thank you very much.
You're welcome.
Your questions about our campaign. For the last years, we established a campaign for the education of the public. Dr. Sarah Haba, she came with this idea and it was repeated 3 times. She did it in the public, in the malls, we started in the hospital, then in the malls, and this year she will go to the patient somewhere else because just to share our experience, actually yes, we start to educate our patient and the educator is the consultant. We choose our consultant to go out in the malls and inshallah, in this year we will go to Wizard Italy. Wizard Italy as the target, we are targeting the teachers and the student, inshallah. And we are planning, alhamdulillah, we found a very good response in the last 3 years. A lot of the patient, when they are thinking the vaginal delivery is very hard, it's very harsh, it's traumatic, they have to change. And I will tell you a story, it's a real story happened in the campaign. When we had the campaign in the mall, one of the patients, she came and she said she is previously scarred and she is planning to do cesarean section. We take her for the section, we have about 12 sections. One of the sections is about VBAC. And they explained to her about 30 minutes, and alhamdulillah, she agreed to have the VBAC.
at the same, and she came to our hospital and the OBD, and she tried her chance. So yes, I think in education, we will show, inshallah, the benefit in decreasing the rate. Thank you.
Well done.
In addition to education, we have to encourage using epidural analgesia during labor. And this is very important. If there's no pain, they will be happy and they will be encouraged to
يعني that is
vagina.
يعني that is the most thing that make people يعني young women يعني go for vaginal delivery knowing that the pain will be controlled. But it comes with epidural that the physician should be liberal at doing instrumental delivery. يعني you cannot have epidural and then just watch the patient in second stage for 2, 3, 4 hours. So يعني it has to come together يعني. And this is يعني has been recommended in many studies that if you go for epidural you have to be liberal with the second stage instrumental delivery. or nothing يعني no epidural اللي هي طبعا دائما الميدوفري ليد يونت يستخدمون اشياء مختلفه كثيره يعني. But you are absolutely right. This is يعني one of the attractive points in having vaginal delivery is not to feel the pain.
Especially
Yes.
the labor hall. The midwife and labor hall understand they should be very kind with the patient, with smiling, and the patient should be relaxed and it should be a good experience, particularly for the final guide.
Yeah. One of the things يعني we did in KFU is the policy regarding the support person. طبعا what you said is really important, but يعني people are different. Some are very tough even with themselves, so you cannot ask them to be nice to others يعني this is their personality. But having a support person يعني the mother or the husband all the time with the laboring woman is I think يعني one of the best thing that we can do to the patient, and it has been shown that it decreases the rate of cesarean section presence, and it also decreases the duration of first and second stage of labor. يعني labor works in a magic way يعني having a support person decrease the duration is هذيك الآية.
You know, DORA is part of the subspecialty of midwifery. I mean, supporting person being, like you said, if there is the midwife is harsh or the physician is harsh. So one of the solutions, because we have a big project for us in the military hospital, 16 hospitals, DORA wasn't one, epidural of course is a must, honestly. Now we should entertain ولادة بدون ألم, okay? But DORA it was one of the things that we needed to initiate it as part of our project. And you know, we should really encourage to have at least $1 per shift.
Yes.
That will help a lot, and it will definitely this will increase the birth age.
وأنا جالسة قبل شوي دكتورة نورة قالت الموضوع ذو شجون، وهو فعلا ذو شجون، لأن يعني if you think about labor في الآية هذه العجيبة فكلي واشربي وقري عينا، يعني مريم عليها السلام she delivered alone and الأمر إنه كلي واشربي وقري عينا, so maybe they should be just relaxed. Thank you so much.
شكرا. Thank you. Thank you دكتورة نورة. Thank you دكتورة نورة. يعني فعلا السبجكت it is endless في الدiscussion و I think it worth طبعا. بس أنا I have a video I want to share it with you. Which I got it yesterday and I got inspired with it صراحة for you to have it with me. This small video. Seema, let's show you. Cursor, it's not working. Cursor.
الشاشة شغالة بس تديرينها لللابتوب. ما عندنا شاشة اوكي يس ننزل ده
just see and enjoy.
لحظة ما شبه
لحظة, just focus, just a moment.
الفيديو تحية
مش
أنا كتير حطيت على سكتة
Respected colleagues, if you don't mind,
هو الفيديو
is blue color Ford with the number plate 1888.
ثاني يوم تجي تسوي
خلي
It's blocking the way, but it belongs to anyone who wants to use it.
ايش السيارة بنعمل؟
فورد سيارة فورد في الماضي أو أسود اللوحة 38 حاسي.
الحمد لله مو سيارتي يعني التفاصيل ما لها دخل لا نفس الشيء دقيقة هو الشوزة حق العرض رجعوا نختار شوزة ثانية هذه بس لازم ترجعوا لها عشان نشوف طريقة.
This is for Dr. Nawal. This is for you.
طلعنا إخلاء طبي في طائرة الإخلاء نفسها إلى مدينة الملك سعود الطبي.
هي المريضة في مستشفى الباحة شخصوها إنها مشيمة ملتصقة ومخترقة الرحم وإلى الجدار الخارجي وعلى المثانة. مع السفر يبدو أن الفرع عندها طلق. فهذه ما تصبح. فأخذناها بالليل جهزنا الدم فريق واشتغلنا بالليل بفضل الله.
بعد العملية اكتشفت إن حالتي فعلا كانت خطر.
خطورة المشيمة المتقدمة بالنسبة للأم والجنين النزيف الذي يسبق الولادة، وهذا قد يؤدي إلى وفاة الأم أو استئصال الرحم. إذا المريضة ما وقعت للعملية جت حالة إسعافية نزيف شديد وما معها أحد من أهلها جاب الهلال الأحمر والإسعاف وحطها على طوارئ، اثنين من الاستشاريين يوقعون انتقال الحياة يقومون باستئصال الرحم عشان ما تموت، عشان الوفاة. يعني ممكن تموت على التيبل على الطاولة يقول لك بس خلاص وقف القلب. فعادة إذا المشيمة فوق وهذا الوضع الطبيعي فإن الجنين يخرج أولا وثم المشيمة تنزل وتخرج. لكن إذا كانت المشيمة مغطية في الرحم فهنا تجي المشيمة المتقدمة إنه تسبق الجنين. في بعض الحالات نستأصل الرحم استئصال كامل ويستمر في النزف. هذه يسمونها post hysterectomy hemorrhage، يعني كذا ينز. تعرفين الجرح لما يصير ينز من كل مكان كذا، أحيانا تفقد المريضة 8 لتر 7 لتر، معناته دمها يتغير مرتين.
وضعي هذا بصفة عامة مستحيل أنسى مدى الحياة.
وانتهت العملية، المريضة رحت لعناية مركزة، بعدها بيوم صحيناها
أخذتها وهي في الحضانة. طبعا صراحة حسيت بسعادة وحنان، يعني كيف الحمد لله سبحان الله ربي أنعم علينا وياها الحمد لله بالعافية وإن خرجنا بسلام من هذه العملية. دكتورة نوال كانت يوميا لدرجة أحيانا تضربني وهي بعبايتها، يعني مخلصة من دوامها والعباية تدها وتجي لازم تشوف الموقف. هذا من فضل الله عليها.
الله يحفظنا على الأمانة.
That was really inspiring فيديو دكتورة نوال، ونتمنى أن كلنا يعني ما أقول نوصل لمرحلتك يعني، بس نحاول نكون في الطريق إلى نكون زيك. شكرا دكتورة نوال لهذا يعني شيء. عشان ما بفتح مرة حميدة صح؟ حميدة يا ستارت.
To the next lecture with Dr. Hamida Ahmed Kadem, consultant anesthesiologist, critical care and pediatric anesthesiologist. She was the previous chairperson of anesthesia department in Maternity Children Hospital Dammam. Her presentation is in regards of anesthesia concerns in placenta accreta spectrum. Welcome, Doctora.
Assalamu alaikum. Sabah al-khair. Good morning, everybody. It's my pleasure to be today with you. أول حاجة, I want to thank Dr. May. شكرا دكتورة سيما for the nice introduction. شكرا دكتورة May for being very active department and educational activity, and invited everybody to be part of your inspiration as well. Today I will talk from the other side of the operation room, from anesthesia side. What mainly I will outline in my topic. Already this topic is covered by Dr. Lamia Mashkoura yesterday, and about the epidemiology and diagnosis and the obstetric management since yesterday until early morning, until a few minutes ago. So mainly I will concentrate into the other part of the story, the team response to hemorrhage, how to prevent the mortality, protocols and team approaches, hemorrhage management, transfusion, therapy strategy, and massive blood loss, massive transfusion protocol, and getting some talk about anesthetic management for such cases. The last activity we talked in anesthesia about anesthesia for cesarean section. So today mainly we'll concentrate about what is different from others. The team response to hemorrhage mainly it will concentrate into prevention. درهم وقاية خير من قنطار علاج. And that's what first lecture was talking about. All data from UK and France talked about the inquiry about the maternal and the children both, and they said it's preventable. That's why we all here today, just to prevent the catastrophe, because the mother is the cornerstone of the family. So if you save the mother, you save the whole family, and that's what we want to concentrate on today, and that's what our goal is: the safety of the mother and the baby as well. So in every step of managing the patient, the message is to avoid delay. And yesterday, Dr. Nawal mentioned that the early diagnosis of the problem is the key point of the treatment as a whole. So avoid the delay, starting from even the diagnosis that this patient is having a problem. This is not the usual course of having postpartum hemorrhage as a whole, because accreta is one of the postpartum hemorrhage, is one of the differential diagnoses, apart from the atony and all other diagnoses you work with in your OB suite. So avoid the delay, make sure that your diagnosis is good, and then from there you could start your management. Starting with diagnosing the hypovolemic shock, which is not an easy. That's why the surgeon came with this classes and all management related to every step in this. But the problem is to diagnose it. You have your patient to get into the to the hull or to the edge of the hull before you discover that patient is in shock and she is needing help, because the physiological changes of pregnancy, it's different from one patient to another patient. Tachycardia could happen, and even the classes, it cannot be like ABC and you will find it on the patient immediately. You have to get your patient to frequently either you examine or you get into trend of vital sign and all other investigations. One of the things that we use other than in obstetric is to have the pre-shock or pre-getting into the hull with the knowing the pre-arrest or pre-problem stages. That would be the warning sign that tells you that's not an easy thing to go. So you will have your patient telling you that I'm having a problem, but please help me before I'm getting into the hull really. Please, can you kindly just scan this barcode as we have to take a look in the protocols that the team could approach this patient. This protocol is already it's already by national partnership for maternal safety. This consensus bundle is to prevent the catastrophe that could happen from not managing well such a patient. In this bundle, they were looking into readiness, reporting, and system learning, and recognition, prevention, and response. You can find in every step what to do just to make this bundle works well in the hospital. So in the readiness, every unit has to have the hemorrhage cart with all with everything that ready surgical or medical to control, like Bakri balloons and everything. You have to have immediate access to hemorrhage medication. You need to have the massive and emergency transfusion protocol, which will we talk later. And every step has its own requirements to get into this bundle. The transfusion therapy. What are the risks of anemia for such a patient? Has already the pregnant lady has already physiological changes and a dilutional anemia by itself. So the risk of anemia is even more with hemorrhage. Oops. Sorry, we have to have always a balance between the risk associated with the problem and the risk associated to the solution to the problem. So the risk of anemia is in a pregnancy per se is high, but if you weigh it with the risk of associated with transfusion, depends in your clinical judgment as a physician. Those risks associated with transfusion is more or less related to either immunology or either to the volume you're giving to the patient or the foreign body you're getting or foreign fluid that you're getting into the body and the body reaction to it. So we have the hemolytic transfusion reaction, although it's really very rare and it has its own symptoms. The TRALI, the transfusion-related lung injury that could happen up to 6 hours after 6 hours post-transfusion, and it could even happen at 1 or 2 units only. Viral transmission with all effort if the blood bank to get it the least they could, but it's still there. The bacterial contamination, especially with the platelets, because the platelets are usually just needs to be on the room temperature, which makes the bacterial contamination is more likely. A TREM, that's the transfusion-related immune modulation. The immune modulation, it's not necessarily like you have the reaction against foreign body, but it is more or less even immune suppression for the patient. And it has been discovered even a few weeks after transfusion. And as well, the transfusion-related overload, cardiac overload, that could get your patient into tachycardia more, even with the treating of the anemia. What are the transfusion strategy that they looked over the literature is to get liberal or restrictive, depending on the starting hemoglobin. A lot of studies goes into that, but the one they mention is the one in compact in Iraq, between the year of 2002 and 2003 to 2005. They studied about 149 patients, and they get really high hemoglobin level, in a patient with 10 and more, and they give them blood, and that was the liberal, and they get into restrictive that gets the transfusion at the level we do these days, around 8. So the Association of Advancement of Blood and Biosynthesis and American Society of Anesthesia together voted, or they get into the restrictive more than the liberal because of the all adverse effect related to blood transfusion. And they said it's not only the hemoglobin per se, but you have to get with the hemoglobin level the symptoms your patient is in, like in tachycardia or the differentiation or the blood pressure, along with the blood pH. Actually, the blood pH is very difficult to be changed. Or very difficult to be low, or the patient will be acidic until the hemoglobin falls below 5. So you have to have a very alarming sign if your patient has low pH secondary to hypoperfusion. One of the other indices of low perfusion is a lactate. When the aerobic converted to anaerobic and gets all the lactate as a result of the metabolism. The urine output, the low urine output less than 0.5 to 1, and the mixed venous saturation as well. How do we treat the massive blood loss? What is your aim, or what is your endpoint that tells you you're doing well, or you finish your job as a physician, that your patient is good right now? So one of the sure sign is that your patient who's tachycardic now, the heart rate is within normal, and the urine output getting the target of 0.5 to 1. and the serum lactate start to go down. Because you're not looking at a spot, one point of diagnosis with one number, but you have to have a cumulative or trending of numbers. And signs of improved organ perfusion, one of them is the urine output, or the mentation of the patient was unconscious and become conscious, and stabilization of coagulation, that would be with the blood bank or blood laboratory tests. How do we treat the massive blood loss? All as a physician, we have to have some idea about blood and blood product, like packed blood cells, plasma, platelets, and cryo. And we have also the fibrinogen that doesn't belong to blood bank, that's a shelf medication. In the fixed ratio transfusion, how do we choose what to give and how much to give? There are a lot of studies as well. One of them was by Bergman et al. And he studied plasma to Bacter BC's ratio, and it's in very different ratio. And they found that the high 1 to 1.4 was the highest survival rate compared to the other. But going back into the data, the death because of low 1 to 1 to 8, they failed to prove that it's just per se because I transfuse 1 Bacter BC's, 8 Bacter BC's and plasma, but because the plasma needs time to thaw. So that may be belong to delay of getting the product, not to have a low ratio by physician order. How can we build up our own mass transfusion protocol? First of all, we have to ask ourselves a question. Do we need the transfusion right now? Okay, or we need it for later, for anticipated need for future transfusion. And all of our management it needs to have endpoint or goal-directed therapy. Where are we going to go? Where is the end of our journey? And if the anticipated need for future transfusion, that's in the elective or scheduled case, we will just go with the cross-match and we tell the blood bank that we need those blood products, and we'll delay the intervention until cross-match blood products are available. The patient is elective for tomorrow's list, or the patient could wait and not having like an active bleeding, so we can wait. Just we'll have an order for the cross-match. The problem will come if you need the immediate transfusion. The immediate indication of immediate transfusion right now, the patient will go to the OR right now. You have to anticipate the total requirement. Is it more than 4 to 6 Bacter BCs of unit or less than 4 to 6? If it's less than 4 to 6, we'll have to have emergency best available blood type if the patient is an active bleeding right now and I don't know, she's unboxed and coming from somewhere and I don't know what to give. So we can really, if it's less than 4 to 6, we can give her the universal unit. But in case, the other scenario, if you need more than 4-6, that is the massive transfusion protocol. So in this case, we have to involve the blood bank and tell them, I need this, I need more than the usual amount of blood. So this is an alert to everybody to start the ratio, and we have like a protocol to send blood laboratory. It depends on your assessment, your patient, and most of people, they do it every 30 minutes, and that's what we do most of the time. What is my goal in those situations? When I say, okay, I'm satisfied, discontinue massive transfusion protocol. When your hemoglobin getting more than 8, first of all is to control the bleeding, of course. If you control the bleed, if the bleeder is there, even with hemoglobin more than 8, you should continue to give a blood. But you have to get backed RBCs ready, at least if you are in good tertiary hospital, you have to get for at least 4 units to be readily, if I ask for them from the fridge, from the OR, it will come to me inside the OR. Cryoprecipitate or fibrinogen concentrate, I want to have the level. Fibrinogen level, of course, it will be by lab, but our aim is to get more than 200. The plasma, I will stop getting plasma if the INR less than 1.5 times the upper limit. And platelets, most of the physician will be satisfied if a platelet count is more than 50,000. One of the pharmacological management that we use in the OR is the tranexamic acid, which is one of the pharmacological medication that could help you in active bleeding. Because the active bleeding causes conception of coagulation system. This is our massive transfusion protocol in our hospital. Massive transfusion, the activation through the blood bank, and then this step just in case that the system is not working. If the system is working, we'll have to go to prepare the request. Then we go through the policy. This is the policy, all in the portal of our hospital. This is one of the patients I did with Dr. May. Those at the end of the surgery, those all the products we gave her. This is in August, last August. The patient survived and extubated the second day. I did myself, although I'm pediatric. Okay. For the pharmacological treatment, the problem with the coagulopathy or thromboembolic nature of the pregnancy itself, that you cannot tell, is it hypercoagulable state or is it thrombotic state? So this is a dilemma that can be solved with the new machine, the vasoelastic machine or Rotem. But we don't have it, unfortunately, we don't have it in our hospital. We used to have it in National Guard, and we use it for all liver patient and non-liver patient. This will tell you exactly which stage you are with your patient. Is he getting thrombus or getting over bleeding? So one of two medication we usually use, recombinant activated factor 7, which is medication. It's recombinant, so it's usually sensitized in the body, but in some cases like hemophilias and some deficiency diseases, you have to use it by hematologist, of course, the specialized person, but we still use it, and it's off-label use because of the likelihood of thromboembolic event. The ASA guidelines says that if you give everything, if you give back blood, so plasma, cryoprecipitate, and everything, then you consider it. Why? Because it's very expensive drug. Okay, I used it on one patient. Okay, I used 7 ampoules. Okay, and everyone is maybe 1,000 to 3,000 riyal, the one ampoule. So it's very expensive drug. No. The tranexamic acid the first 3 hours, but for this, if you get everything and get you all everything, and then because my patient was arrested, and they do ligation for bilateral ligation, hysterectomy, and everything, and the patient is still bleeding. And I asked for help from intensivist, and he said he had nothing to do. Then I decided to get to this patient. Okay. The antifibrinolytic therapy, the one you said that you have to get it within 3 hours. This woman trial, they have the very international double-blind controlled study in 193 hospital over 21 country, and they get the conclusion that the dose of 1 gram slowly over 10 minutes would decrease the death secondary to hemorrhage without increasing of the side effect. You can repeat it once after 30 minutes, and in the woman trial, they used it within 3 hours of starting the postpartum hemorrhage. Okay, we reached to my part, the anesthesia for peripartum hysterectomy. Neuroaxial or general anesthesia? What would you choose?
You can start with that one. If you want, you can convert it at any time.
Okay.
College of Anesthesia recommended in Euraxia.
It's recommended to go, but for me, I will not. I will not. Well, I had, you see that patient that survived in August, okay? The second patient, I had maybe 1 month later, I put for her cerebral oximeter and SID-line, cerebral oximeter, really, just in case she arrested, I know where I'm going, okay? And this patient who arrested and was arrested in the OR, by the way, and then we put for her arterial line, central line, and everything. Honestly, even there is a study, okay, and they claim the conversion to general anesthesia 20%, 21%. I don't believe in that. Okay, for me, if there is a bleeding, I don't want my patient to feel like she is falling from 20 flight. Okay, because this is really what they feel. Even with the spinal, when they're dehydrated and don't have good preload, they will feel like falling off 20 floor. Okay, yeah. So to start with the neuroaxial, and it's written this way by ACOG, as you said, and you have to accomplish T4 sensory level. Just sedation, because once, by definition, the laboring mother is full stomach. When you give sedation, you burn your bridges, okay? So you get her aspirated. That's my point, okay? And then if the patient is already in labor epidural, I can top up her, but single spinal anesthesia will not be enough, especially if the surgical time is getting more. When the surgical time getting longer, so the sensory level will come down, and the patient will feel every single move. So I will be liberal with my threshold in getting into general. And as one of the studies, 21% only, and there is one study in 29 patients, they said no patient converted to GA. But I don't believe, there is... combined spinal epidural is always a good option, okay? But it has, you have to get contact with the patient all the time and see the mentation how much. The sedation here will block this. So if the patient is sedated, but you don't know she is her hemoglobin may be low and her mentation is altered either to the sedation or to hypovolemia and having low hemoglobin. That's a problem. It masks the effect of hypovolemia. General anesthesia, there is a reported case of cardiac arrest because propofol is very harmful to the heart and the big vessels. So if the vessels are not really filled with the fluid or whatever blood, the patient will get arrested immediately. And be very generous with intravascular volume and fill the tank and squeeze with the vasopressor. What is different in anesthesia for the peripartum hysterectomy? I will make sure that I have more than 2 large IV, or I will put a central line. Okay, the central line will help you in both, in getting product and getting samples to assess where are you. Invasive arterial line, of course. Blood bank on board with the 4 units packed RBCs at least at the tip of the hand, and you will have the whole whatever. We have non-invasive cardiac output monitoring. We had it in one of the hospital I worked in. It was very helpful. It shows you how much your cardiac output beat by beat. So those non-invasive dynamic monitoring will tell you what you're doing. You're getting into right track, or you just delayed. Or that's why afterwards, all my patients, I put cerebral oximeter. I want to know if the brain is working or not. What are blood conservation technique that we have? We all know about the allogenic blood that we're getting from the blood bank. There is the autologous blood transfusion, a non-pregnant lady, of course. The preoperative antepartum donation, not recommended. Normovolic hemodilution, again, not recommended. One of the doctors said anemia is prohibited, the same.
No, but we are using Cell-Salvage.
So, yeah, but for that's the question I want to ask since yesterday. Intraoperative cell salvage. I used to use it in scoliosis. Ideally, what happens is with your suction, you will get your blood into a reservoir with a lot of filters, and then it will go into centrifusion and filtration, and then it will get into a bag, and you're getting back to the patient. This is one.
It should be after Liker.
Okay, yeah, or you have double. You have double suction, one to the Liker, and afterwards you just change it to other one. Because one of the concern is the isomerization and maternal mixed with fetal blood, and still no data about the complete safety of it, because of this part, that the fetal debris and the fetal blood might be in contact with the mothers. But though the ACOG has stated that in case of suspected placenta, cell saver should be considered if available.
Is this the latest?
This is 2017. Okay. And also, American Society of Anesthesia had the same word about it, that they recommend you use it. And this is the latest evidence as well, the latest task force in obstetric anesthesia. So in summary, obstetric hemorrhage is the most common cause of maternal death. Severe morbidity, mortality can be preventable. That's why we are here today, to discuss what we could do better in terms of preventing the death, if possible, whenever it's possible. The peripartum hysterectomy is increasing, and there is always alarm sign and high risk for massive hemorrhage and massive blood transfusion when it comes to the percreta or brevia or any abnormal placentation. The multidisciplinary team response has to be educated and we have to do education and re-evaluation, and we have to do drills as well, just to keep up our protocol or our practice, and have feedback about what you were doing well and what area to improve. Coagulopathy is one of the nightmare for anesthesiologists as well as post-operative management by any healthcare provider. Tranexamic acid could decrease death and had its effect in blood loss and transfusion risk. Thank you for listening.
Thank you so much, Dr. Hamida. Questions for Dr. Hamida, please?
أيوة.
They
أيوة.
all been told إن هو فقط use maternal
Only
20%.
the, yes, that's all.
Whenever the other uterotonic have been failed. هذا كلمتهم.
Yes, and that's it. Yeah. And actually, they don't recommend immediately, and the bleeding continues more than 30 minutes. So you have it in hand. If and we always give it upon request of obstetrician in the OR.
بس حبيت أوضح
Yeah.
هم قالوا 20% can reduce maternal death if other uterotonic have been
Yes, have been failed and.
طبعا احنا our policy is نفس الشيء. We are following مش the first line all uterotonic. We are using oxytocin
with the methadone and everything. Yeah, I read a lot of studies in this, and they said that they are superior, even they're superior.
WHO recommended to use it, even we are using it prophylactically.
Highly recognized.
Any patient with mesenterplegia or patient with extensive adhesion with massive blood transfusion, admission to the ICU, we are giving it with the induction anesthesia.
Yeah, and for the.
If you need it, you can use another dose after 3 hours.
Yeah, but.
So this is the recommendation of WHO.
بس إيكوك آخر إيكوك طلعت women trial big women trial.
Yeah, women in 20,000 patients. Yeah, in 20,000 patients.
This is what we are practicing. What's your experience, Flora?
Tranexamic acid يعني صراحة موضة.
But يعني نفس ال.
Prophylactic. We didn't encounter anything with prophylactic. Actually, the WHO recommended prophylactic. The WHO and
بس عشان بس.
But yes.
يعني كستيتمنت. إيكوك كتبت الستيتمنت هذه exactly. كتبت كنت أقرأ على اليوتروتونيك والأشياء هذه والترانزكسيميك قالوا آخر شيء يستخدم if uterotonic have been failed ويمكن
Not only for this for
الستيتمنت حقتهم قالوا 20% only can reduce maternal death in low resources
setting.
أنا بالنسبة لي على طول إذا خلص اليوتروتونيك ما نفع معي على طول تجيبوا لي ترانزكسيميك موجود مش موجود على طول نتبع الأشياء هذه. جدا رائع دكتور محاضرتك يعني
and it should be within 3 hours بس it should be within 3 hours وفي شيء ثاني كمان prerequisite to use it if you use it without fibrinogen يعني if the fibrinogen is less than 200 يعني you're just يعني كأنك بتكبي قبل ما يصير okay but in severe bleeding and you didn't give it you have to give. Do you have fibrinogen in your hospital? Fibrinogen concentrate.
بس مش على طول يعني احنا very exhaustive center.
احنا we had to use it بعدين اختفى بس it's very helpful لأنه compared to cryoprecipitate it gives 10 times the product.
بالنسبة للدكتورة سلفاج يعني بأول experience دكتورة نوال.
Regarding the silk sulfate, we have silk sulfate. There are two types of silk sulfate. First one, it will give you only the RBC. And this machine is difficult to use. Anesthetists trained to use it. Not all anesthetists will like it because it's only the other silk sulfate give you the RBC and the coagulation factor.
And plasma.
It's easier use. Everybody can use it. This is the second one. We're trying to get the second one. Regarding tranexamic acid, is carry the risk of thrombosis. And if you give it as an up-to-date recommendation and with the skin incision, maybe your patient won't want to bleed massively, and then you will carry the risk of thrombosis. And you have one case like this. This is number one. Secondly, regarding factor 7, the use of factor 7, it should be patient with high coagulation factor. But in these cases, usually the patient will go to the IC. So it's useless to use it unless you give her a transfusion factor, all the factors.
Yeah, after finish, yes. Yeah, at the end.
It's very expensive. I think 7,000 for
في لأنه في شركة حتى ال1 أمبول 1000 بس إحنا مثلا اللي في ال MCH 3000 I think. Yeah.
But is it useful or not? I should
make sure. Yeah, but it's the last.
All the factors should be filled. If she not
filled,
and use the drug, it's
بالنسبة بس السيل سيفر it has been used في الهوسبيتال اللي كنت في by the transfusionist because there were cardiac center. So with the transfusionist it was easy. For anesthesiologist, I never seen anesthesiologist use it. Okay, and they failed to. أنا as MCH or Ministry of Health, I would consider the cost because the cost in the literature it's between $300 to $800 مو سعودي ريال يعني per patient. So this cost should be considered. Okay, okay, but if I okay, thank you.
مركزنا دكتورة our center most of our patient unknown so we don't have this readily blood product available فبيساعدنا هذا
كثير لأنه هو حيشيل موضوع الكروس ماتش خلاص دكتورة ما يتوسط لنا نجيبها حتى لو بمليون ريال.
لا وفي مرات it's much better than the blood from the because that one old RBC
with the all straight and potassium and
this is a fresh hair on blood.
Yes.
And it will raise hemoglobin faster than the blood transfusion. They know this our anesthetists.
Okay. في سؤال ثاني؟ Thank you. الله يفيك.
The lecture part in this symposium with Dr. Fatma Qasim Al-Yusuf, Consultant Anatomic Pathology in Maternity Children Hospital. She was the lab director for 1 year and currently she is the section head of histopathology lab and her presentation is histopathology findings in placenta accreta spectrum. Please, Doctora, تفضلي.
Good morning, everybody. I would like to thank Dr. Ramey and the organizing team for inviting me for this nice symposium. I will talk to you about the placenta accreta spectrum from pathological point of view. These are the outlines that I will concentrate about them. I try to be, not to be specific, I didn't go in too much details in my presentation, so hopefully it will be easily digestible and accessible for everybody. As you know, the placenta accreta is the newest clinical terminology spectrum of disease associated with abnormal placentation to uterine wall, resulting in partial or complete retention of placenta at the time of delivery. Usually we diagnose cases of placenta accreta on hysterectomy samples, whether total hysterectomy or subtotal hysterectomies, but sometimes when we receive delivered placenta or dilatation and curettage samples from retained product of conception, we can see a specific finding of placenta accreta. These cases, we call it basal plate with adherent biomaterial fibers. As you know, the placenta accreta can be divided into 3 categories. Accreta represents 75% of the cases, and pathologically can be divided into 3 categories: focal, partial, or complete, depending on the number of the lobules which are involved. Placenta increta represent 18% of the cases. Placenta percreta represent 7% of the cases, in which, as you know, there is invasion beyond the serosa or involvement of other organs, such as urinary bladder or the fat. Regarding, I will talk briefly about the etiology and pathogenesis of the placenta accreta spectrum. Most of studies have shown that the causes, the main causes that are poorly understood or not known. But most of them, they related to a deficiency of decidua. As you know, the decidua is the hormonally influenced part of endometrial stroma, which act as physical or immunologic barrier. Also, it's associated with the impairment of extravillous trophoblast, or impairment of smooth muscle fibers or myometrial fibers, which in turn lead or related to reduced decidua. And these cases are associated, as you know, with recurrent cesarean section and increased number of cesarean section, implantation in the lower uterine segment, which is called placenta brevia, and also frequent or recurrent instrumentation of the uterus, such as myomectomy, dilatation and curettage, and endometrial ablation. Now I will concentrate about the importance of a clinical pathologic correlation. I think you hate this statement in our report. But regarding this entity, as you see in this study, they demonstrate the importance of the correlation. It was multicentric studies, and they found that 18 to 29% of cases didn't have pathologic diagnosis or confirmation of accreta, despite the clinical diagnosis. And despite most of these cases, they have thin wall of the thin uterine wall, which is less than 3 millimeter. So the correlation is very important for us as pathologists, and we have to work as a team. It's considered as a quality improvement tool to evaluate the outcome of management and the effect of the hospital's practice. And it's very important for the pathologist to participate in multidisciplinary team and to provide a standardized diagnostic assessment. Regarding clinical presentation, as I stated before, as pathologists, to diagnose placenta accreta, either we diagnose it on hysterectomy or subtotal hysterectomy sample. This situation is called placenta accreta. Or, as I said, we can make diagnosis on dilatation and curettage or delivered placenta. These cases, we call it basal plate with adherent myometrial fibers, or previously called occult placenta accreta. The diagnosis is very difficult, but I will talk about it later. Now I will give a brief talk about the gross feature of the pathological samples. As pathologists, we receive several types of specimen for pathological assessment. Sometimes we receive hysterectomy with separate placenta, each organ separate, or we receive a hysterectomy with attached or in situ placenta, and sometimes we receive delivered placenta, either intact or disrupted. And we can make it, as we said, on dilatation and curettage sampling. To start with, as a pathologist, we have to do a gross description of the sample. As you see here, this is what we call it uterine remodeling, in which the uterus becomes elongated and it has boggy appearance with the prominent blood vessels in the lower uterine segment. And when we do extensive examination here, in the other figure, the uterus has bulging from the placenta, which can be related to two causes, either to surgical manipulation or due to abnormal placentation. So after we receive the sample and we examine it grossly, we do gross inspection. We do sagittal incision or coronal midline incision. The middle photo demonstrates placenta accreta. We examine the placenta. We try to push it, whether it's easy to be pushed or not. We do manual manipulation. And we examine the area of attachment of the placenta with the uterine wall. As you can see here in the middle photo, the placenta is attached to the uterus without invasion. The myometrium is very clear. After that, we do serial sectioning and what we call it breadloafing. And we take the sections for microscopic examination. You can see here in the third photo, section from placenta with attached serosal surface and attached bladder. This slide, I think it's important for pathologists. When we take some sections for microscopic examination, we don't take them randomly. We go in special manner. There are special areas which should be submitted for microscopic examination. In this situation, we have to submit area from the placenta uterine adhesion, or what we call it placentation site. We have to submit from the area, normal area, and we have to submit from the other organs, such as umbilical cord or fetal membrane. When we receive sample of hysterectomy with separate placentation, with a separate placenta, and the patient is postpartum with hemorrhage, we have to put in our consideration the placenta accreta again. So we have to sample the implantation site. It's very important, and that's why we said also we have to have good communication with the clinic, with the surgeon, and sometimes we have to read the operation note to know where is the implantation. Like here, it's not clear where is the implantation. In these cases, we have, when we don't know where the implantation is, we have to do extensive sampling from the anterior lower uterine segment, especially if the patient has bleeding, postpartum bleeding. When we receive a placenta with the suspected placenta accreta, it's either fragmented or intact. As you can see here, it's intact, almost intact placenta with central disruption. In this situation, we have to concentrate on the area around the disruption. We have to sample it. So higher yield of identifying adherent myometrial fibers microscopically by sampling the intact basal plate adjacent to disrupted area. When we receive cases with retained product of conception, the gross description, it's very difficult in these cases. So we have to do liberal sampling of the cases, and we have to submit the entire tissue. Now I will talk briefly about the microscopic feature. The normal histology, here we are concerned about the placental disc. It consists of two plates, fetal surface and maternal surface. Fetal surface, it consists of chorionic plate or chorionic epithelium, amniotic epithelium with fetal blood vessel. And the basal plate, which we are concerned about it in the placenta accreta spectrum, it consists of decidua, which is absent in the placenta accreta, and chorionic villi. Here we have the normal endometrial stroma or normal gland and normal stroma, not hormonally influenced. When we talk about decidua, this is the decidua. The stromal cell, they will turn into bubbly cell with eosinophilic cytoplasm around the nucleus with a prominent nucleoli. This is the decidual cell. And it's normal to have these cells, which are the junior pathologists, maybe they will think that these cells are decidua. They are not decidua. They are extravillous trophoblast, which can be present in placenta accreta. This is the normal histology of term placenta. As you see, the chorionic villi, they turn into small size. We have large stem villi and small terminal villi, and immature villi, which are in the first trimester, which is dilated and ballooned. Extravillous trophoblast. Here, it's normal to have it in the corner or polar surface of the chorionic villi, and sometimes we have it like this, a collection of cells. This is very normal retained product of conception. Now, the normal implantation, when we have normal uterus with normal implantation, as you see here, this is the chorionic villi. They are attached to the muscle with decidua. Here we have the decidua, and here we have the fibrin layer. This is the normal histology of the placental implantation. But in this inset, you have the placenta accreta, in which we lose this layer. This layer is totally missing, the decidual layer. This is a microscopic picture of placenta accreta. As you see, the chorionic villi is attached to the smooth muscle. The decidua is lost. But here some pathologists, as I told you before, they might confuse it with decidua. This is not decidua. This is extravillous trophoblast, which can present in placenta accreta. But the normal decidua is lost. And here I want to tell that the myometrial fiber is normal thickness also. It's not affected in placenta accreta. In placenta accreta, there is invasion of the chorionic villi into myometrium without decidua, and the myometrium become thinned, a little bit thinned, with extravillous trophoblast, and the fibrin layer become less. Placenta percreta, as you know, there is invasion of the chorionic villi into the wall beyond the serosa. Here we have the chorionic villi. There is no myometrial layer, and usually when we handle case with the placenta accreta, we deal with it like cancer cases. We put what we call ink. So it will be easier for pathologists to do microscopic assessment of the specimen. Here, the chorionic villi, they are adherent to the fatty tissue, and here we have the fatty tissue, which is abnormal. It's placenta percreta, and the myometrial layer is lost. Other findings which can present in placenta accreta spectrum or any other abnormal histology. This is non-specific finding. Inflammation, edema, edematous changes when there is like fluid between the fibers, and the blood vessels, they have remodeling. They become enlarged and they have invasion of extravillous trophoblast. This is not specific finding for placenta accreta. As I told you before, the basal plate with adherent myometrial fiber, this diagnosis we make it on delivered placenta or on dilatation and curettage sample or after delivery. This is a case of delivered placenta with feature of placenta accreta. Here we have the myometrial fibers and chorionic villi. And this is not decidua. This is extravillous trophoblast. So these cases, they are prone to develop placenta accreta in the future. And this kind of diagnosis, it has a special staging system, but it's not used. It's proposed, but it's not used. It depends on the size of placenta, size of the decidual layer, whether it's present or absent, and the thickness, we can measure it also, and the foci of abnormality also, it will be calculated by pathologists. But it was proposed, this system, but not used. These cases, whenever we diagnose it, the patient will have the risk of getting placenta accreta in the subsequent pregnancy, and it's associated with many abnormality in the placenta, such as all of them or almost all of them associated with maternal vascular malperfusion. On DNC, as we said, gross examination is very difficult. Even the microscopic examination is difficult, and it depends on the duration of the tissue in utero. Because once it's getting longer, it will be influenced by factors, and there will be a lot of fibrin and necrosis, so it will be difficult to assess. I will give a brief introduction about proposed new grading system for placenta accreta. It was proposed 2 years ago, but it's not used in most of the centers, including our center. They claim that, in this study, they claim that the previous system, accreta, percreta, and increta, it's a categorical system. And it has the disadvantage of being inconsistent, and it doesn't reflect the current knowledge or pathogenesis or need of the clinical team. So this new system, it's a descriptive grading system, and it's parallel the FIGO grading system. They use this study as a claim. In this study, they did a systemic review and meta-analysis of many cases, and they found that there is inconsistency between the pathologists regarding diagnosis of placenta percreta per se. So, according to them, this system is very more descriptive and more consistent. This proposed system are designated as grade based on the degree of invasion, gross invasion, assessed and local tissue destruction. As you can see here, grade 1, when it resembles placenta accreta. Grade 2, when there is superficial invasion into the myometrial layer with the preservation of more than 25% of the myometrial thickness. Grade 3, it can be divided into 3 categories, 3A, D, and E, depending on the amount of invasion of the myometrium. This system, it has high reproducibility, and it will improve the reproducibility, and it decreases the discrepancy in the diagnosis from clinical diagnosis. Here more details about it. According to them, grade 3A is parallel to cesarean scar dehiscence. It has 2 patterns. When there is invasion or abnormal placentation of the placenta, or when there is the cesarean scar dehiscence. That's why the gross examination is very important for us as pathologists. The top slice or section represent abnormal placentation. As you can see here, there is abrupt transition from the placenta into myometrium like this. This is abnormal placentation. And here, cesarean scar dehiscence. There is what we call it wedge shape transition or gradual transition from the myometrium to the scar. This is the microscopic photo of it. And about grade 3D, it represents any form of uterine wall disruption. So here it's very important to have correlation with the surgical and radiologic finding. So the communication between pathologist and surgeon will increase the accuracy of the final report, and it helps us to know whether this invasion is a pathological invasion of the placenta or post-operative or due to operative manipulation of the specimen. And the communication between pathologist and the surgeon can be elevated and improved by including the specimen in the requisition form, writing data in the requisition form or in the system, and also reportable element can be documented in the request form, such as whether the specimen, when it's fragmented, it's difficult for us to determine whether there is other organ attached to the uterus or no, like a bladder or fat or whatever. So it's very important to have these details in the request form. Grade 3E, as you said before, it represents invasion beyond the serosa and involving other organ, whether it's bladder or parametrium. This is to summarize the grade 3E. Clinically, 3E represents 3B and 3C. On clinical, on FIGO grading system, 3P represent invasion into the bladder, and 3C represent invasion into other organs such as parametrium. But with this new system, the pathologic new system, they merge these two into 3E to involve bladder and other organs. I will talk briefly about the cesarean scar dehiscence. It represents an incomplete disruption of the uterine wall at the site of a prior cesarean section. It's usually occur in the lower uterine segment, and most of the time when we examine it, we see a part of a placenta protruding through the wall. Here we have the gestational sac protruding from the wall. As we said, this photo, I showed it to you before. This photo, the top one, demonstrates the abnormal invasion. And this one, the cesarean scar dehiscence. And this represents the importance of a gross examination for pathologists. Microscopically, these lesions will show the wall consists of fibrous tissue only. It will not have myometrial fibers. And sometimes also it consists only of fibrin and blood. It's deficient in a smooth muscle fiber. And to make it more complicated, sometimes the uterine scar dehiscence will have placenta accreta on top of it, so we have to be careful and we have to do extensive sampling of these cases. Now, the clinical implication of the diagnosis, as you know, I will give it briefly, to affect the future fertility if the patient have hysterectomy or subtotal hysterectomy, and regarding the basal plate with adherent myometrial fiber, it will, if we diagnose it will increase the risk of getting placenta accreta in the subsequent pregnancy. And also, the cesarean scar pregnancy or implantation, it will lead to miscarriage and recurrence of in the future, and also it can lead to subsequent placenta accreta. And the retained placental tissue can lead to infection and hemorrhage. Thank you. Any question? Any question?
Thank you so much, Victoria. Questions? Assalamu alaikum. Thank you very much for the lecture. I have a question. If you have came across any studies correlating the actual histopathological diagnosis, whether it is placenta accreta or placenta accreta stricta, or just the lesions of the scar, and the correlation to the radiological examination. Because for us as clinicians or surgeons, we want to go in the surgery knowing whether it is actually adherent
Or
just
placenta
lesions.
accreta.
Because with lesions, you can just excise
Yeah.
the area and leave the uterus and save and preserve the fertility.
Yeah.
Have you come across something like that?
I didn't come across a study like this, but you mean uterine scar dehiscence, right? To differentiate between placenta accreta and uterine scar dehiscence.
Yes, and compared to the radiological image.
I didn't see study like this, but I can search for you. And the studies that I have read about is about the correlation between pathology and clinical finding.
Thank you, Victoria, for your presentation. My question is, did you come across pathology specimen with the bladder, and did you notice any invasion into mucosa or muscularis master? Because the serosa is outside, but I'm talking about muscularis and mucosa of the bladder.
You mean the difference between invasion to the wall versus the mucosa?
No, I mean, did you have any case of partial cystectomy in your pathology lab? You noticed that there is tropoplastic tissue reaching the mucosa or muscularis invading them?
No, I haven't been across cases like this. I never received cases like this. But regarding the new grading system, that's why I concentrate about it. They never differentiate. They didn't differentiate between the mucosa, the involvement of the bladder mucosa or the bladder wall. They considered them the same.
Because the serosa is outside, I mean, just matter of adhesions, it is outside.
Yeah, we make this diagnosis whenever we have invasion into the wall. I didn't get your question.
I mean, because there's a new thing that placenta accreta is not invading the bladder.
Yeah.
So to say it's invasion, we have to have plastic tissue and then mucosa of the bladder or muscularis.
Yeah.
The serosa.
Yeah, it gave us a hint about the depth of invasion. Yani when it involves the muscularis layer, it means it's more superficial. But at the end, it's placenta accreta. It will be considered the same category, especially in the new system.
Just a question and comment. Dr. Noura, yesterday I discussed with Dr. Maawiya. They should have a research about the correlation between imaging and histopathology. And I think, Dr. Anwar, I'm happy if you have a center like this. I saw that it would be a good research question to correlate so you can just have an effect on the future for any special patient. My question, you said that sometimes the surgical manipulations may interfere with the histopathological finding.
Mm-hmm.
Do you have any advice regarding our surgical approach so we can modify so not to interrupt with your histopathology finding?
It cannot be, it's not avoidable, I think. And that's why they put it in under the same category in the new grading system. They consider it in this category 3D. They consider them 3D, whether it's due to surgical manipulation or due to abnormal placentation.
Any specific type of surgical, it will not go through anything that we should avoid as a surgical.
I haven't been across a study like this. I think it's unavoidable. But it's we usually tell the surgeon to be gentle with the specimen and not to disrupt it. It's better to receive intact specimen instead of fragmented or disrupted samples. It will make the diagnosis more difficult. That's it.
Thank you, Dr. Fatma. Sometimes we after patient uterus, we intentionally open the specimen just for teaching purpose
to show our residents, or maybe this is the disturbance it bothers you.
Yeah.
But I think yes, it should be screened and
Yeah, it must be opened by pathologists. As I told you, we put ink to demonstrate the area of invasion. We deal with it like a cancer case, especially the placenta accreta samples. We handle them like invasive cancer cases. So that's why the...
We are curious about, the extension in the endometrium, myometrium. We like you know. انجي هنا باستفاضة.
خلاص تعالوا تفضلوا anytime.
يعطيك العافية.
الله يعافيكم. Welcome.
Thank you, everybody. Now just I will show you a short video. I received it from Mr. Yesterday. He gave it to me. Unfortunately, he had some social issue. He had to left. So I will show the video. Then after that, we will take one session only for the workshop. After that, we will go for lunch and prayer. Then we will continue the rest 3 sessions. The video will be about the Jovanovsky, I think.
We present an article in American Journal of Obstetric Gynecology, a technique to preserve the uterus in patients with placenta accreta spectrum disorders. Completed scientific study carried out within a framework of international cooperation between the University of London and the University of Oxford. The retrospective control study, including 147 patients with PAS, the main group of 95 patients who underwent the the comparison group consisted of 52 patients with traditional control. Individually, 4,000 girls are registered in the Omsk region of perinatal century. The perinatal century is focused on the treatment of severe obstetric pathology, during the 1,000 to 3,000 cesarean sections performed every year. In recent years, we have seen grow the number of placental abnormalities. Last year, we observed 54% of pregnant, 17% of pregnant, and 13% of hernias. In technique to preserve the uterus in patients with placenta accreta spectrum disorders by Professor Sergei Barinov was developed and implemented in Omsk region of perinatal center in 2014. The combined method of delivery includes several steps. We start from the conjugational balloon catheter installation after the blood catheterization before abdominal delivery. The evaluation of wall segment condition was performed after laboratory. When PAS was revealed, it is overextension, bounding to the lateral pelvic wall and increased vascularization were observed. The PAS size was measured. We make a fine transparent incision on the uterus for 5 centimeters higher than expected location of the upper edge of the placenta. The fetus was extracted from the uterus. The umbilical cord cut and ligated with pus and prayer. After the extraction of the fetus, we inflate the conjugational balloon catheter, 180 milliliter of saline solution. The uterus is pulled through the womb. The descending branch of the uterine arteries are ligated from both sides of the posterior uterine wall. This line shows the high and low levels of the uterine vessels ligation. Surgery step for PAS 1 and PAS 2. The excision of the site was performed with simultaneous application of the hemostatic uterine assembly supraplacental suture developed by us. PAS 2 if the area of placenta accreta is more than 2/3 of the thickness of the myometrium or in diameter more than 5 centimeters. We perform excision of a part of the uterine wall with the placenta accreta area. Then the uterine wall is repaired with separate real suture. Here we presented a dissection of hernias. We used the Pelosi maneuver when separating the hernial cells. Placenta preta resect by sharp dissection with simultaneously application of hemostatic clamp. After hemostasis was achieved, Zhukovsky uterine balloon was expelled. Passing it through a hysterotomy incision into the axial tube of the vaginal catheter. The comparison of the wound angles was carried out in the rear using a modified assembly suture. The wound of the uterus was sutured with 2 row horizontal stitches in the form of a wound. Study on the effectiveness showed that despite of the high rate of placenta preta, the number of hysterectomy cases in the main group was 4.5 times lower than in the group of comparison. The small volume of blood loss after the compression method of hemorrhage management required less hemotransfusion in the main group. In the structure of intraoperative complication, while the injury was observed more often in the comparison with the main group. The inpatient time after delivery was 10.5 days in the group of comparison and 4 days shorter in the main group. According to our data, 12 women after metroplasty induced a subsequent pregnancy. Here we're presenting this scar after 1.5 years after metroplasty, and in the same patients, the scar of the uterus in 4.5 years after the 2 consecutive metroplasty. Conclusion. A combined approach with the use of Zhukovsky double balloon tamponade in patients with PAS increases the number of organ-preserving surgeries, decreases the number of hemotransfusion, and decreases inpatient time after delivery. The proposed technique of uterine wound suturing contributes to the formation of a competent uterine scar, which provides further successful pregnancy.
This is the one that you made it cover yesterday.
Now we will be dividing ourselves into 4 groups. Our candidates, please, if you will notice, there are color codes on your tags. Each color code will be assigned to one of the workstations. We have the navy blue workstation starting over here, which is the surgical management of postpartum hemorrhage with tips and tricks, and over there the yellow team. It's about the tamponade balloon or Bakri balloon. The green team will be joining the internal iliac artery ligation station, and over the red team is the B-linch, the original and the transverse B-linch. Just before we come to these sessions, please, we would like to have a group picture of all of us, so if you will just join us on the stage.